So I think that Preeti, we can go ahead and get started. And thank you everybody for joining us today for our first live question and answer session for our recorded webinar series with the Sheikh Khalifa Stroke Institute. We hope that you enjoyed the presentation, and we look forward to launching our next presentation with Dr. Victor Urrutia later today. And for today's session, please start with any of the questions that you have. I would just ask that before you start, please introduce yourself and your organization for your questions, and then Dr. Raghavan is going to address the question. Other option is you can type the question on the chat box, and then we can cue them to Dr. Raghavan. Thank you so much. Preeti?
Yeah, great. Thank you very much for being here. I know I have one question from Dr. Anwar. I could start with that if you like. Dr. Anwar, would you like me to talk about the execution of the precision rehab?
Yeah, Preeti, first of all, I must say that an excellent presentation, very informative and very thoughtful. You remember when you were here last time in UAE, we had a discussion on stroke rehab, and I tend to agree with you on most aspects which you presented in your presentation. And as you know, our model in Abu Dhabi is very similar to what you're proposing. So we have a full complement of rehabilitation across the continuum, starting with acute care in Cleveland Clinic and hyperacute rehabilitation there, followed by outpatient services either in Cleveland Clinic or inpatient here, and then home health care under Amana Healthcare. So we have the full complement. And our inpatient is showing excellent outcome measures, with over 90% of our patients being discharged home, probably 94%. Just going back to your presentation, I put forward one question there. I was intrigued by your concept of precision rehabilitation, and I think this is something we rehab physicians have always talked about. What is the best rehabilitation you can provide? And so I want you to just comment on that. I know you did comment on for the outpatients, you described 4 levels, and it does make a lot of sense. But what's your views about a similar model for the inpatient rehabilitation? And the secondary question coming from there was that I was very intrigued to see the 6 hours, not therapy, but training. You described 6 hours of training in your Johns Hopkins program. And then I know most of the rehabilitation facilities struggle to get in 3 hours of therapy. In Amana Healthcare, we have 3 hours of therapy, but we try to build on that with the nursing input, which obviously they are there with the patient for 24 hours. So there is not a lot of nurse-led therapy programs that we put forward, and then there is the use of technology, which the patients can use when therapists aren't around. But I just want you to talk about your 6 hours of training as well. We want to just hear what that entails.
Great. Well, thank you very much. Thank you for your comments and for taking the time to listen.
Yeah, just got on a little late.
So the idea of precision rehabilitation is very much the same across the continuum, that we provide the right amount of training, the right intensity to the right patient. So broadly, that's the idea. In terms of execution of this on the inpatient facility, on the inpatient unit, we have a research project going on where we are piloting this. The idea here is that, again, let's say we take a patient with severe upper limb impairment, or upper limb impairment in general. You have a spectrum. You have those who have severe motor impairment. There's a combination often of motor, cognitive, and other kinds of impairment, speech, right? So, so basically the idea is to, right now, it's pretty much standard to give 1 hour of, say, OT, 1 hour of speech, and 1 hour of PT. Now, clearly we tailor it, but can we give, let's say, 2 hours of OT to someone who has primarily a severe motor upper limb impairment, right? And then tailor all the other therapies according to what they need. The way we're trying to titrate, so we're really trying to titrate the therapy to the patient's needs more closely, and trying to do this by integrating the one-on-one therapy plus the technology that the patients can use on their own, plus group therapy, plus in-room therapy. So the idea is to give patients a home exercise program, like we give patients a home exercise program on outpatient. It's to give them an in-room exercise program while they are on the inpatient units. And the idea here is to educate them that rehabilitation doesn't begin and end with their interaction with the therapist. It's really a way of life that we have to educate them on so that they can continue this while they're in the hospital, in the room by themselves, plus when they leave the hospital. And so actually for us, during COVID, we got to experience, because we had to use technology much more to deliver rehabilitation, we were able to pilot this concept within the inpatient rehabilitation unit as well. So we used certain pieces of technology that enabled remote, balance training, remote upper limb training, things like that. So that's the broad idea. And the implementation of it is what we are piloting right now.
Okay.
Does that answer your question?
Yeah, absolutely. And I think we try to do the same. So there is this minimum of 3 hours of therapy input, but we do a lot of stuff beyond that. And as I said, we feel that rehabilitation nurses are the most important tool in the whole thing. And people don't talk about them as therapy, but these are the guys who are doing a lot of rehabilitation stuff with these patients. A lot of cognitive rehab stuff is going on. We use them for our spasticity management with stretching program when therapists are not around. They are a big part of the training, and as education and training is the bigger, and you talked about self-management program, and the nurses are the pivotal, play a pivotal role in that.
Absolutely.
So I get your idea. The thing is that as a rehab unit, we are not counting the time as part of the therapy. So at the minute, what you say is 3 hours of therapy. And as you say, it's 1 hour at least physiotherapy, 1 hour of speech therapy, or 1 hour of occupational therapy. Now, but we are very flexible in that 3 hours. So if somebody comes in like a TBI patient whose physical impairments not as significant as the cognitive impairment, we tend to give them more occupational therapy rather than the physical side of things. And so if they are not needing the speech therapy, then the 3 hours is then divided between the physiotherapy input and occupational therapy input, plus what they can do with the family, what they can do with the nurses, or as you said, what they can do themselves as a part of self-management. So right. I get your idea about 6 hours, but as I said, we do additional things, but these are not counted in that time frame. But as you know, in rehab, this is a 24-hour process.
Exactly.
Take advantage of the 24 hours that the patient is in the hospital.
Yes, that's the idea, and that it's a team effort. It's everybody Absolutely. Is involved at all times.
Yeah.
Right.
So thank you very much for elaborating on that.
Other questions?
Hi, Preet, it's Casper speaking. I'm one of the intensive care physical therapists and educators here at Cleveland Clinic Abu Dhabi. I'm joined with me with Aisling, Edward, and Vinod, and Amanda later on. The presentation you delivered was really interesting. The model of care, we are an acute hospital, but we have a little bit of a blurring of the lines in that. Although we are acute, but we don't really do 1 to 3 days. We probably do 1 to 10, 1 to 15. And I think it's because we deliver the rehab, the acute stay plus a bit of the inpatient rehab before people go on to a residential rehabilitation facility. And then depending on insurances or whether people need to hang back for repatriation, we may hold on to them for a bit longer. Mm-hmm. 3 hours of therapy a day is a target for us, not always achievable. However, I agree with Anwar, I've got your name right there, Anwar, that, you know, any kind of goal-directed treatment could be classed as therapy. I don't think you can patent the word therapy to physiotherapists or occupational therapists. They may not like that because they want to protect their turf, but I think therapy in the broadest sense would have to be the interpretation on it if we were to try to switch to your suggested model, which is a 6-hour therapy session per day. I really like the presentation. I am curious as to how you can get to 6. I would like to quiz you a little bit further on that as to how you think that may be feasible in other centers. Secondly, the breaking down of the silos I think is hugely important. And the contribution there is really looking at our KPIs from being what we do internally to actually following the patient and working in teams of teams, but the focus is the patient going through the continuum as opposed to worrying just about our metrics in each of our areas of work. And I think, you know, for us, we've got stakeholders within our community here, Amana Healthcare, for example, that take on a lot of our patients from the acute setting to the rehabilitation setting. And we've entered into discussions about how could we standardize some of the outcome measures between our two facilities so that when we are doing handover and or handoffs, we are at least speaking a similar language when it comes to measuring the patient's progress. Interestingly, we did not see the FIM in your presentation, nor the Bartel, any of the measures that, you know, typically would be of a CARF style accreditation facility. So I'd just like to get a little bit more input. I know that you've come up with that outcome measure template and that you've deliberated over it extensively. So some rationale there too would be wonderful. Thanks.
Great. Thank you so much, Casper. So I think you bring up some really important questions. One is, you know, what happens in the hyperacute stage? You're in acute hospital and the length of stay is not necessarily just, you know, 3 or 4 or 5 days. And how do you get 6 hours of therapy there, right? Is that what you were asking? 6 hours of therapy sort of wherever?
Yes.
Yeah. So that clearly that's a challenge especially in the very early stages. And I think I can tell you a little bit about our model in the hyperacute stage. We are not aiming for 6 hours in the hyperacute stage, though it would be nice. Why not? Would be my thought. What we have been able to do is create a system to provide 3 hours in the hyperacute stage, which was itself a pretty big deal because it does require, you know, changing the way everyone is deployed and changing the workflows. So in the very early stages, we have something called the ARISE program, and there will be a grand round on that. It stands for the Acute Rehabilitation Intensive Services, where the physiatrist, along with the team, decides what the patient needs. And instead of giving it in 1 hour blocks, we are giving, the idea is to give patients who require, let's say, occupational therapy, at least 2 sessions. Those sessions may be shorter or longer. It depends on the patient's needs. And it also depends on how much they can tolerate. And sometimes it may be helpful to co-treat. If a physical and occupational therapist co-treats, maybe you could give a longer session and maybe help the patient get to a higher endurance level if you're trying to increase their tolerance. But I think, to your point, we tend to think of therapy in very specific ways, right? We tend to think of it as that being delivered by occupational therapists, physical therapists, and speech therapists. And maybe we've got to shift our mindset to think of it in terms of what the patient receives. You know, how much mobility, how much ADL training or language, cognitive, and other training they receive overall, as all being counted towards what they are doing while they are under our care. So the idea is, you don't want the patient to be inactive and alone. You want to involve them in their own rehabilitation to the greatest extent possible, starting day one. So it's really about what the patient is receiving rather than just what we are delivering. Maybe that's one way to think of it. And in that regard, every single thing that we do matters. What the nurses do, what the therapists do, what the family members do, what the patient does, all of that could technically be counted. And the idea would be that, to the greatest extent possible, the patient is being kept engaged and they are involved in their care. In terms of standardized outcomes, so yes, you're right. We did not include the FIM and the Barthel for a couple of reasons. Number one, the FIM is actually being phased out in the US. So it used to be the standard for inpatient rehabilitation. It was the reporting standard, but there were floor and ceiling effects. And so now we have the G suite of outcomes that we have to use on inpatient. And the Barthel, again, even though there's a lot of literature on using the Barthel, again, if there is, it doesn't give you detailed information. I want to also, take this opportunity to elaborate a little bit more on what we are trying to achieve with precision rehabilitation. There are actually many ways to define it. And the way I defined it previously was, broadly, it's about giving the right treatment to the right patient at the right time and at the right intensity. But in terms of operationalizing it, one of our goals at Hopkins, we have a very large precision medicine institute, which really started off with looking into genomics, looking at, understanding the detailed profile of an individual and tailoring the treatment to them. And in terms of rehabilitation, operationalizing it, could, if you dive deep down, it may be using continuous outcomes like kinematics. We are piloting a study right now where we're going to use the Fitbit on every patient to look at their mobility and their heart rate. So we have a continuous measure of how they're doing in terms of their mobility. So I think that the idea is to choose outcomes that have greater information content. And for that reason, we are moving away from the FIM and the Barthel. Now, you could argue that some of the other outcome measures that I put in the presentation are not as detailed, and you may be right. But we are right now trying to strike the balance. So if you remember one slide, and I can share some of these slides again. If you just give me one moment, I'm going to join from my computer as well. And share my screen here. Let's see. So if you look at the screen, basically, we wanted to have a core minimum data set of measures that could be collected as part of standard of care. And then on top of that, we thought we'd add additional evaluations like kinematics and things like that for research purposes. So the thought was to really have, to the greatest extent possible, measures that are high information content that can be used to triage patients, that could also inform the therapy that the patients are going to get. So they're not just assessment tools. They help the therapist or the team basically understand what is it that can push their care forward. And potentially it could be used for research as well to assess how the patients are progressing over the long term. So that was the basic idea of the outcome measures.
Thanks for that, Preeti.
Sure, you're welcome. Does that help answer your questions?
It does, and I am fascinated because I suppose one key thing is that when we're talking about migrating from a model of current state of play to a more sophisticated model, or a model that offers more care, you're anxious to show the benefit of it. Mm-hmm. And the departure of outcome measures because they're being phased out as a rational justification. I'm just trying to work out, because in the literature, when you're benchmarking the successes of what you're doing now, so much of the literature uses those old outcome measures. So I don't know how you're going to compare, contrast. I know that here we use the functional status score for the ICU, which is a sister child of the FIM built for ICU that we've kind of given for the whole of acute care.
Yeah.
And what we like about that is that the bed mobility, transfers, ambulation are so nicely covered with that in terms of the level of independence or dependence the patient has, for us to be able to track the patient progress from ICU into the acute setting, which, as I said to you, is kind of a merger of what you have in the States of the hyperacute stay and the acute stay.
Yeah.
And whilst we'd be keen to adapt these functional outcome measures, yes, I suppose we're eager to show that migrating to this new model of care, we would be able to show good progress.
Yeah, and I think that's why a dialogue is necessary. The goal here is not to tell you or dictate, as to which outcome measures one should use. I think it would, if there are outcome measures that you feel are valid and you're using them, there is already a system in place, then it might be a really good reason to use those, to continue to use those. So I'm not, I think our goal is not to sort of to tell you to pick one or the other, but really to help make a decision based on the situation that that you have out there.
Understood. Thank you.
Other questions, comments for Dr. Raghavan? Anyone from Saha institution in here?
There are two of us here. We've got myself and Pratap. But Khalid got my question. I was curious about the 6 hours. That's a very ambitious plan, but we've already addressed that.
Okay.
Hi, this is Aisling here from Cleveland Clinic. I just have a quick question for Dr. Preeti.
Sure.
Thanks, Dr. Preeti. It was a really interesting webinar. I really enjoyed it. My question is, I thought it was really interesting how you had two pyramids. Kind of the typical strategy, I think, is for, we tend to sometimes, the patients that are more, yeah, exactly, that's it. And the patients that are more dependent, we tend to give maybe less therapy too. And I know you did show studies that obviously with chronic strokes, sorry, I'm just going to close this door. Sorry, with chronic strokes, that they can improve with more intensive therapy. But just my question is, how do you pick the patients where you have more intensive therapy? Because certain patients just, this brain injury may be so severe that, you know, no matter how intensive therapy you implement, it won't really result in functional outcomes. So is there any outcome measure you use for criteria of who we spend more time with than others?
That's a great question, Aisling. Thank you. So again, broadly, the idea here is that we tend not to give enough therapy to those who are really severely impaired. There is a tendency to write them off and to send them, you know, to subacute or to nursing homes where they become invisible, and, you know, we don't really give them a chance to fully recover, and that they might have a chance, right? You're talking about brain injury. We're as a whole talking about brain injury and stroke, and there are many different outcomes that are used to triage. So I won't go into that in detail today, but I was what we are trying to do. So this is what we did. So there is, I don't think people in the UAE have heard very much about the AMPAC. There will be a grand round on it. The AMPAC is a patient-reported outcome measure. Now, it doesn't have to be patient-reported. It could be a proxy-reported outcome measure. But that is a measure that was developed using the ICF criteria. So it's a reported outcome measure that incorporates the concepts of impairment, function, and participation. The nice thing about the AMPAC is that it gives you clear cutoffs of what the patient is able to do. It could be used in the hyperacute stage, in the inpatient stage, and in the outpatient stage. And there are normalized scores that allow you to determine where the patient is. There's going to be talk just on that measure and how we use it. And so one way, you know, now it's highly correlated with other outcomes. So you could, you know, make a rationale for potentially using other outcomes as well. But because this could be used throughout the continuum, and because it has clear cutoffs, it could be one way to operationalize, you know, how you divide this pyramid, you know, who belongs to this least functional category and the middle category and the most functional, right? And then you might argue that in the least functional category, if you want to maximize their intensity and time for rehabilitation, you know, they can't really tolerate the amount of therapy we give them, right? And that's sort of been the rationale for maybe sending them to step down care until they are ready. So I think that there are, you know, many different scenarios to consider. But I really wanted to make the argument that we shouldn't be locked in to our current models, right? Because if this is the current model where, and we do this all the time, we select our patients to go to acute inpatient rehabilitation based on their potential to go home, right? So we are selecting the most functional patients out here, or the ones with the greatest potential, at that moment. But we are ignoring the potential of these currently least functional patients. They need the intervention the most, right? So, I don't know exactly what the best balance is. I think we need to talk about it. We need to figure it out. But I think we definitely are not doing the best by every patient that we can, given the information that we currently have. There's been just so much literature out there on, you have a 6-month window of recovery and that's it. And when I see patients past 6 months, and they are continuing to recover, some of them said, I didn't even know this was possible. I gave up. And now I know that I can, I'm 2-3 years, I'm 10 years post. And if I knew I had the potential to recover, I would have worked much harder earlier on, right? And I wouldn't have had to waste so much time. So I think the idea again here, the big picture, is that there isn't any such rule that there is only a short window of recovery. I don't even believe we have done the studies where we have compared the rate of recovery early on versus later on, in the best way possible. There have been studies on the proportional recovery rule, and they have looked at, that there's much more recovery in the first 3 months than later on. But I think there is a lot of missing information in some of those studies, which is what we need to get at. We need to understand how to push the boundaries, because those can be pushed, rather than, boxing patients into categories of recoverers or non-recoverers. So I think that's the key point I want to make.
That's great. Thank you, Dr. Preeti.
Sure. Thank you, Aisling.
Just to clarify, Preet, actually, that's really interesting. So the AMPAC allows you to classify the patient's recovery, and then within that classification, you actually have goals for rehabilitation to get to milestones. So even if you're a really dense stroke with what might look like traditionally having very little potential for recovery, that would put you into a classification within the AMPAC system. I know you don't like me using the word classification, but you get what I mean, into an area of the AMPAC system that allows you to then play with treatment options that allow you to achieve, even if their impairment milestones, they're not big enough to achieve a functional gain, you still may achieve impairment milestones. Is that kind of what that allows you to do?
That's correct. So the AMPAC, it does help to categorize patients, and then within each category, you applying, let's say, the rules. So that's the idea of taking some outcomes that will inform exactly how you're going to treat the patient, and then to design these individualized treatment plans that can potentially help the patient get to the next level in the AMPAC, right? Now, the AMPAC may or may not, we're going to be able, once we use this on a larger scale, we're going to be able to see how sensitive the AMPAC is to change. There is literature on it, but I think that's why we want to use, I don't believe there is literature on the sensitivity of the AMPAC for change in patients with stroke they've looked at it in several different diagnoses. It's a rehab tool overall. But I think we will have this opportunity to look at how the various precision rehabilitation treatment interventions enable you to push past the threshold of one category to the next.
Interestingly, do you guys have to deal with a DRG system on your inpatient stays? And if so, how did you manage to convince the administration to double down on OTs and PTs and SLTs when your typical for cost divided by DRG per therapy input, now you've doubled it, which essentially looks worse on your costs or your productivity output? Do you just know how to navigate that system to, if we were to try to increase the level of intensity of care, we do have DRGs here. How do you get around that?
Yeah, well, so right now, that's a brilliant question, and that is the $1 million question, right? What will the payers do? So we don't know, right? We have to work within the system. We are not, we don't have another source of revenue to deliver clinical care per se, right? We are dependent on for right now, we're dependent on whatever is dictated down to us. But I think this is the moment in time where we have the opportunity to change the system by demonstrating that what we do can change the outcome, right? And I think in the UAE specifically, we have this opportunity because, the government has brought us in to help decide what the ideal care should be. And so, there's potentially that openness to listen and to change based on what we as a community decide is important for the patients. And I think when payers have traditionally thought of rehabilitation, and there's tons of literature on this as well, the idea has always been about cost savings initially, but when you don't mitigate the disability, when you don't treat it early on, then you actually increase the costs later on. Right now, that there could be cost shifting, maybe that's somebody else's problem. But I think as a society, if you're thinking of taking care of the people in the community, then I think it becomes important to think about long-term disability as well. And, as I just mentioned, if patients who are moderately, severely affected in the chronic stage can actually recover well, why not give with intense therapy, why not give that therapy up front or whenever they're ready? If they're not ready in the hyperacute stage, well, you cannot push it on them. They're not ready. They may decompensate. Well, you give it to them when the time is right. How do you decide when the time is right? You've got to still monitor them and make sure that you find them at that right time, and you are then able to give them the treatment that they need. But the idea is that it shouldn't be somebody else's problem down the road. It's our problem right now to do whatever is possible to mitigate the disability. And we would have to use the assessment tools, the outcome measures, to demonstrate to the payers that this works, that this is what will help them in the long run reduce the costs. So I think that's again the argument that still needs to be made through data.
Hi Preeti, this is Pratap here. Can you hear me?
Hi Pratap. Yes.
Hi. I'm from Alain, the smallest city in Abu Dhabi. Thank you for your presentation. I didn't have a chance to watch the last webinar, so my question you may have answered my question. But with regard to the 6-hour therapy, I just wanted to query whether there is sufficient evidence to advocate that strongly, because the point I see often is larger volume of therapy doesn't necessarily translate into larger functional gains. And there are studies in the past, I haven't looked at the recent ones, to indicate that may be the case. So is it based on a strong evidence that larger volume of therapy is beneficial, or is it a system change you're trying to initiate?
So the key, so thank you, Pratap, for joining and for your question as well. So I want to, basically, there are a number of articles that have come out fairly recently that have shown that it is the amount, it may not be the time, but it's the amount of, amount of practice that has to be delivered over a period of time. So this is an article by Janice Daly that came out late last year, where they asked two pivotal questions. One was, do patients actually plateau? They were referring specifically to patients with upper limb deficits who were moderately severely affected. So the Fugl-Meyer scores, were not too low here, but in the 20s. And they asked, if you gave these patients in the chronic stage high dose therapy, 150 hours, would they improve? And if would they plateau, or if you gave them more, would they continue to improve? And that's what they found. They found that, if you actually gave them high dose therapy, even in the chronic stage, they can improve. Now, they had a set protocol, and the protocol was based on motor learning theories. They had already tested that protocol in other studies. There was another study that came out of University College London by Nick Ward, where again, that was also not randomized, controlled, but it was high dose therapy given as part of routine practice. And again, they found that they were able to give 6 hours of therapy to patients in the chronic stage, and it was given, they either admitted the patients specifically for this program, or they gave them the therapy as outpatients. It was like a day program. So there are practice models out there where you can give high dose, high intensity therapy, and patients have shown gains that were previously not thought to be possible, right? So I think these studies have taken place internationally, so in the UK and in the US. There have been other studies that have taken place in Australia, where they've talked about an enriched environment where, just as we've talked about today, we're not talking only about the interaction between the patient and the therapist as being therapy, where you're creating an enriched environment where every interaction of the patient with staff on the unit, with family members, could become therapeutic if if it is structured in that manner, right? And so the idea is to answer your question, Pratap, there is evidence out there, and it's fairly recent evidence that the patients can improve given the high intensity therapies, and time seems to be of essence, especially if we use that time to provide the therapy that they need, the practice. So there could be other elements in that model. So it could be dose, it could also be the socialization of the patient and the engagement, the emotional engagement of the patient. And all of this fits very well with what is already written in terms of the ICF guidelines, in terms of enriched environments. It's supported by animal literature as to how the biology of recovery evolves. There are lots of bits and pieces in the literature, but how do you pull it all together to sort of reconceive of the way we provide rehabilitation is really the question that I'm trying to address here.
Thank you, Preeti. My laptop battery is running out, so I'm moving out from one room to another to charge it. So I have one thing I just want to point out to you is when you were talking about disability, persistent disability, and which will impact costs in the future. I just want to point out UAE has kind of some unique demographics. As you probably know, 90% of our population are expat workers, and if the expat worker is disabled, I don't think generally they will stay back. So the disability is probably inherited by the parent country. So the health economics therefore may be different for those people. So it was interesting that Caspar brought what we call the D word, because DRG is a big thing, which really is very challenging for us to provide rehab in acute care. Probably is not an issue for people like Khalid, where they work in a different pay system. So DRG is a big thing for us, and after once an expat worker is disabled, gets the primary acute care, and then after that they are at large. We don't know what happens to them many of the time. So that's that. I just want you to be aware of a unique situation, which you may, it was very unique to me when I started here a few years ago. To say that you don't inherit those patients long term; they disappear.
Yeah.
And Pratap, can I add something just to Pratap, or just it's a bit naughty of me, but the other thing that you've got to look at is the functional participation of many of our patients in society. So the expats have work, big societal roles to return to. A lot of our elderly Emirati patients tend to either be at home, so unemployed, be surrounded by maids and workers. And it's I find as a physical therapist, it's very difficult to establish goals with the patient that they truly want to be able to go and do anything other than really just return home. That's not, of course, everyone across the board, but certainly trying to tap into goals. And so it's not just the severity of impairment that's driving us and whether or not you're an expat, but really it is what role were you playing in society? If you're a parent or a worker or someone who has goals to really get back to high level functioning, you as a therapist, you tend to give that person a hell of a lot more time and attention than someone who really would be quite happy sitting in a chair at home, and so there's that factor to it as well.
I think sorry, Caspar, I just wanted to, it's a big factor, which was again a kind of shock to us when we started working, and to me in particular, I'm sure for Caspar as well, is I think we can rehabilitate here if you're just treating and caring for just national population. The focus is very, very narrow with regard to rehabilitation as compared to what we have our previous experience would tell us. So I just give an example that we have been our acute care rehab, the OT complement is very, very low. and I'm sure that's the same everywhere. And we can, it doesn't seem to be an issue for many of them, because for ADL, there is always somebody who could do that. So it's a very interesting observation, and an interesting situation which we face in UA again.
Yeah. So I think, again, Pratap, you brought up two really important things, Pratap and Casper. So on the one hand, you have expats who worked, who are used to perhaps doing a lot, but they are going to leave. And then you have other folks who are not used to doing a lot, who now have to participate in rehabilitation. And how do you get, how do you deal with both of these groups?
Preeti,
Yeah.
Khalid here. Can I just come in here for a minute,
Sure.
just to give some aspect from my point of view, because as Pratap was saying, we deal with exclusively with Emirati population. We have very few experts that we see in our rehab setup. And this is exactly what we found, what Pratap was saying about the Emirati population. But we as a team sat and we had a lot of brainstorming about it. So we found ways of engaging the local population in rehab activities, which is very different from what we used to do in UK. So, for example, you would take the patient to a kitchen and you would work with them, in the kitchen environment, work with the ADLs, but these guys are not doing that stuff. So what we did was, for example, for the elderly Emirati patients, they have farms, they have animals, they are very interested in those kind of activities. So we tended to move our focus of ADLs towards that aspect, which was interesting to them. So we would take them to their farms and we would do things with them from the rehab point of view there. And similarly with the female population, they have maids, so they're not interested in going into the kitchen and doing the stuff that they normally don't do. And so we found ways of working with them. So for example, they're very much interested in going to malls and doing a lot of shopping and stuff like that. So we had to orientate our rehab program to the things that the local population are interested in doing. So that was something I think you have to incorporate differently in a culturally sensitive way to the rehab program. So I just thought I'd share that with you.
Yeah, I think you made the point really well, Dr. Anwar. And I think that some of the models that we are testing, which other folks will talk about in detail, where you can simulate other tasks. So using video games, for instance, where you can they could be engaged. The idea is really engaging them in their life roles, whatever those might be, and many people everywhere in the world are not used to moving very much. That becomes a problem, because as I've talked about, immobility being a big barrier. So I think that's the other challenge, that we've got to figure out ways to engage them, to overcome some of these challenges, and maybe we need to think of it differently than we have in the past. ADLs could also mean playing games in a simulated environment where they are doing things that they are not ready to do in the real world, but they can do it as part of the therapeutic environment. So I think there's a lot to talk about on how we actually achieve this. But I think it's exciting that you are excited about this, taking rehabilitation sort of into the next era together, if you will. And I'm just wondering, we are almost up to the hour. Are there any last minute questions or?
Hey, Dr. Preeti, this is Vinod, one of the physios working in the outpatient neuro rehab, CCAD. Do you have time for one more question? Is that what you said?
Sure. Hi, Vinod.
Excellent,
yes.
excellent. So my question is regarding the intensity of therapy that you mentioned in your model. Like that's kind of runs from 5 times a week intensive therapy to 1 to 2 times a week. So I mean, there is this general belief that the critical window of recovery after stroke, based on cerebral plasticity, is between 3 to 6 months. I mean, there are definitely contradicting evidence there. It says cerebral plasticity can enhance recovery even after 12 months, but there is this critical belief that 3 to 6 months is very, very important. That's where, patients are going to make most of their recovery. And, most of the times, at least in the UAE here, the patients that are being referred to outpatient for physical therapy, they are past that window, way past that window. And how do you, in your model, do you use any outcome measures or any system in place that you use to differentiate, or to categorize these people on how much therapy will be getting, if they come past, if they've been, severely spastic or, immobile, or, and they still being referred to outpatient therapy, maybe after a year or 18 months of, post stroke. How do you look at them, and how do you categorize them into these, the different intensities that you mentioned in your model?
Yeah, Vinod, it's a great question. So I
Hello?
think
Yeah, fine,
just
thank you. Yeah.
the basic idea is that we want to provide the intense therapy early on, but if just because a patient comes later on, it doesn't mean that they don't have the potential for recovery. There's going to be another talk about potentially using the AMPAC, which is what we're using for both ADLs and mobility, to sort of categorize where the patient is in their impairment function participation spectrum, and then to take it from there. So clearly, as I mentioned here, the behavioral recovery requires neural restoration, right? So they have to be able to activate their muscles, but that's not enough. They also need the correct sensory inputs, and if they have spasticity or stiffness, that would impede neural restoration. And then they have to have the endurance. They need to have the cardiovascular abilities to participate in their activities. On top of that, there's the cognitive and all these other meta skills that also come into play. So I think at this point, the key thing is that just because a patient is in the chronic stage, it doesn't mean that they don't have the potential for recovery. You have to assess them individually in terms of what the barriers are and address those barriers. And we have found that if you address those barriers, then you can potentially progress them along the continuum. One of the biggest barriers in the US is the payer, right? Because of the number of visits that patients are given, which is very artificial. How do you decide that 30 visits will be enough for a particular patient? There is no literature or any data to support that. That's totally arbitrary. So where I'm going with this is that we have molded our system of providing care to what is dictated down to us rather than what is necessary for the patient. So by using outcome measures, by creating or designing the care that is appropriate for the patient, we can potentially push past these artificial barriers to get to the point where we can deliver the therapy. The paper that I just have been using to make the argument is that in the chronic stage, if you give high dose therapy, patients can recover, you could potentially open up a new window, right? Is that window biologically the same as the window that occurs immediately after the injury? Maybe, maybe not. But I think that that's what we have to investigate and check out. So I hope that answers some of your question, Vinod. I think there'll be, I'm really excited that everyone is engaged. I think you'd be interested to see what's coming down the pike in terms of other presentations, and I think there'll be a lot of opportunity for dialogue. So thank you very much, everyone, for participating.
Thank you so much, Dr. Preeti.
Thank you all for your time today, and thank you, Dr. Raghavan, for your time. For any further questions about Dr. Raghavan's talk, please send it to the email that I've just shared on the chat box, sksi@jhmi.edu, and we will be happy to route the questions to Dr. Raghavan and provide you with some feedback. The session will also be posted on our website shortly after. And then this way you can go back to it, listen to it, if in case you have any other colleagues that would be interested in the topics that did not get the chance to be with us today. Also, please stay tuned for the release of our new webinar later this evening for Dr. Victor Urrutia, and the details of the talk would be shared also expected coming from the SKSI@jhmi.edu. Thank you all for your time.
Thank you.